I think we should divide the session in two parts. One part we should discuss the 9111 trial, because it's the biggest trial we have to date, to get an impression what is the standard of treatment, of non-surgical treatment. And I will come once again, Jan van Marken, Marshall Posner, and Jan Olofsson. Thank you that you are here. And my first question is, what is the role? You mentioned that at the beginning of your statements. What is the really role of induction chemotherapy concerning larynx cancer, laryngeal cancer? What would you make a statement?
What would I say?
Yeah.
I say right now we don't know the role of induction chemotherapy in larynx cancer. Well, we do know the role of platinum 5-FU and induction, and I don't think it plays any role. We don't know the role of TPF.
And when you say we don't know if TPF is better than PF, what would you expect from induction chemotherapy? A better local regional control or effect of distant metastasis? Are playing distant metastasis any role in laryngeal cancer? Or would you expect that if an induction chemotherapy should be performed, the only reason to do this would be that the local regional effect is better than with radiochemotherapy alone?
Well, I think it's a good question, and it really gets at the meat of what we need to do. And it gets at the question of what population we're going to treat. And I would say, first of all, that I don't think there's one treatment paradigm for all stages of locally advanced when you start looking at T and N stage locally advanced larynx cancer. Clearly, I think I showed that local regional control needs to be better. We had certainly a 30% local regional failure with the concomitant cisplatin, which I think is good, but a 50% failure rate with induction chemotherapy is not satisfactory. So I think there's several roles induction can play. One is we can go back, harken back to lessons from 2 decades ago that induction chemotherapy can be used as a selection factor. It's sort of a crude surrogate biomarker. So that's number one. Number two, clearly it reduces distant metastases. So that would indicate to me that for people with advanced nodal disease, there may well be, which is the group at greatest risk for distant metastases, that would indicate to me a role to study induction chemotherapy in that particular population.
But normally the patients from laryngeal cancer, they didn't die from distant metastasis. There was a question, if the effect on distant metastasis were really realistic as an endpoint, because I've seen only a few patients who die from distant metastasis.
Certainly in this group that I showed you.
Yeah. What is your statement to this?
Well, I have a couple of comments. First, let's start with the notion of laryngeal preservation as in 9111. You'll notice that the survival curves are substantially lower than the laryngeal preservation curve. So what we're really seeing is a false measure of preservation of the larynx. What we're seeing is preservation of the larynx in the presence of death from complications, the so-called unknown death rate, which is probably inanition, aspiration pneumonia secondary to chemoradiotherapy effects. And so laryngeal preservation, as defined in 9111, is really a very strange endpoint as opposed to laryngectomy-free survival, which is alive with an intact larynx. And even that definition doesn't really meet the criteria that I think the Europeans have come up with in both the GORTEC and the RTC trials, where laryngeal preservation is defined as alive, no G-tube, no tracheostomy, no laryngectomy. And I think that is a real measure of the efficacy of organ preservation as opposed to laryngeal preservation as in 9111, which is a post hoc, that is an after the study was done, change in the endpoint, because the original endpoint was laryngectomy-free survival, and because that was a negative endpoint at the time of analysis, laryngeal preservation became a more desirable, I think, endpoint to look at. I don't think there's any question in this study that disease-free survival in 9111 was better, a local regional control rather, was better in the chemoradiotherapy arm. But what you have to look at is the global effects of therapy, and the results of that global effect were actually a higher rate of survival, albeit non-significant, with induction, and an equivalent rate of laryngectomy-free survival, which is the endpoint, alive with an intact larynx. If you look at TAX 324, to go back to the issue of local regional impact of induction chemotherapy, I don't think we can blanketly say that induction chemotherapy does not impact local regional control. The induction study by Pagnella really demonstrated an impact on both local regional control as well as distant metastases with PF. And in the TPF TAX 324 trial, the significant improvement in survival was associated with a significant reduction in local regional failure, a significant improvement in local regional control with TPF compared to PF. So there is clearly an effect of induction chemotherapy on local regional control. If I could have my first slide. If we look at the TAX 324 breakdown, here is the survival for the combined group of larynx and hypopharynx that we had. This is, if we could click please. This had a significant reduction in death, and it was a highly significant improvement in survival for the 166 patients who had advanced larynx and hypopharynx. This included both operable and inoperable patients. If we could go to the next slide, please. Here is a forest plot of that survival, just demonstrating the overall survival and seeing that the impact was greatest in terms of larynx. And it was we required the combined group to really get a significant reduction observed because of those small numbers. But you'll also see that progression-free survival, particularly in larynx, was significantly better, as well as the combined group. Next, please. When we took a look at the patients who were defined as operable, and this was as part of our initial analysis, there were 123 patients who were operable within the larynx and hypopharynx group. If you could click this again, please. There was no significant improvement in survival, although there was a nice splaying of the curves, and perhaps with a later analysis we may see either more or less of this. In the next slide, click it again, please. What we see here again is if we could have thank you. The hazard ratio is 0.03. So we see here in operable patients, and there were 123 patients, a significant improvement in laryngectomy-free survival in larynx and hypopharynx. And this is associated with a significant improvement in progression-free survival, which I won't show the curve. Next, please. So sequential therapy with TPF significantly improved survival in advanced larynx and hypopharynx cancer. It reduced mortality by a significant amount compared to PF. Sequential therapy significantly improves progression-free survival in advanced larynx and hypopharynx cancer. It reduced surgery, and I didn't show the data, by 50% compared to PF, and it reduced primary site surgery, although not significantly. Next, please. It significantly improves laryngectomy-free survival in operable larynx patients. And I think since it's significantly better than PF, you could reasonably expect TPF to be significantly better than Bolus's platinum-based chemoradiotherapy. And we would base this on the 3 trials that compared Bolus's platinum chemoradiotherapy to PF. The Taylor trial, the Forestier trial, and the Lefebvre trial, which did compare a different regimen of induction of chemoradiotherapy. In all of those trials, PF was equivalent to the chemoradiotherapy studies in terms of survival and in terms of laryngectomy-free survival, or in the Lefebvre trial, laryngeal preservation. So I think given the significant survival advantage and LFS advantage in TPF, one could make the logical leap, the extrapolation, that perhaps TPF might be better than PF and then chemo-RT as an extrapolation. So I think it's a reasonable standard of care, and I think that we will know whether it's better or not when the chemoradiotherapy trials are completed, the comparisons with TPF and chemoradiotherapy are completed.
Okay, but we're seeing in this study that you have hypopharynx carcinoma and lines. They're completely different, the main one point, and you compare TPF with PF and say TPF is better than PF. Okay. But there's no randomized trial to combine laryngeal cancer, TPF plus radiotherapy or radiochemotherapy against against the standard. So we should not mix all these things together. We should make very clear statements for the audience. And you want to give an answer to this?
Well, I just wanted to say that I think that we have to keep in perspective that this is a subset analysis of a small group of patients within a much larger study. And so I don't think you can really draw any conclusions from it. You can say that it supports a hypothesis to test the question that Renal just proposed. But I don't think you can draw conclusions that or infer that this can now be an acceptable standard of care treatment.
Well, I
think we have not so much time. A small answer, but then
yes.
We have to continue because while we make something for the audience, we will show you slides from 30 years ago when we treat the patients by laryngectomy. Slides from 75 or 76, and we treat all these patients in the former years by laryngectomy. And now we should discuss in which way we would treat these patients today. But give your small answer, but then we'll have to continue.
Yes, I want to totally agree with Dr. Forster. This is an exploratory analysis which is really confirmatory of the GORTEC data and also has to be taken in the context of being a subset analysis of this study. But I think the data is very compelling, and I think we have to recognize that there is no data supporting a advantage to chemoradiotherapy compared to PF induction at all. And here we see an advantage of TPF compared to PF. You have to be very, very thoughtful about whether you think you could claim that chemoradiotherapy represents a standard when you have something this robust in several trials showing such an improvement, such a dramatic improvement in survival in patients, which were the endpoint of the TAX-324 and TAX-323 trial. So I think when we look at the data, you have to draw your own conclusions rather than listen to me or to Dr. Forestier or to other people as we kind of pound our desk with our shoe and say these things.
So we keep down now, and we conclude for the audience. Mm-hmm. One thing, we need further investigations, and what we mentioned is that if we add induction to the standard treatment for laryngeal cancer, I speak only from laryngeal cancer, you must have a better local regional treatment, a better larynx preservation rate, and in the end, a better laryngectomy-free survival. And the next studies will show us that. But now we come to the practice, to the daily practice, and I show you some typical slides from the 70s. Please, the next slide. Next one. Next one. Okay, so look at these pictures here. These were four samples which have been treated by laryngectomy in the 70s. You see the options that we have today. Surgery, we have the option of classical conservation surgery, that means the open approach. We have the possibility of transoral laser surgery. We combine that with neck dissection, comprehensive or selective. We have the possibility to perform a radiation, standard or a hyperfractionated, accelerated. We can combine the treatments, chemotherapy plus concurrent. Maybe we have some possibilities of other treatments. And I want now your statements. The first statement for Jan Olafsen. How would you treat these carcinomas of the vocal cord? You see there are two T2 and T3 carcinomas. What would be your local treatments today? When you look at the left slide, yeah. It's a T2 No, go back. Yeah.
First of all, it depends on the diagnosis. We are using today, both CT and MRI too. That gives an information about the depth of this tumor invasion. If you go back to the 70s, we didn't really have more than the CT was coming into the arena, but that was just about it. And we had a common radiological tomography, for example, that was something uncertain. We could look at the fixation of the vocal cord, if it was mobile or not. Mm-hmm. We knew that a fixation of the vocal cord meant at that time, and it still means that perhaps close to 50% of those vocal cord cancers invade the cartilage